Okay, let's unpack this. If you are working in the emergency department, you know this is your bread and butter.
It absolutely is. Pediatric distal forearm fractures, the single most common fracture site in children.
Right. But just because it's routine doesn't mean it's simple. These injuries, they really demand precision.
They do, and that's our mission today, really, to distill the essential evidence for the experienced ED practitioner.
So we're diving into that definitive early management,
Hmm.
mastering the art of the close reduction, but also knowing when to stop.
Exactly. Knowing those evidence-based lines in the sand that tell you, okay, stop, this needs an orthopedic surgeon. We want you to be confident differentiating those you can manage definitively in the department.
And those that carry a much higher risk.
A much higher risk of things like growth arrest or deformity.
And the key to all this really is leveraging that remarkable power of remodeling in children. Growing bone is it's so much more forgiving than adult bone.
It is. And understanding the limits of that forgiveness is what helps minimize unnecessary trips to theater.
So let's equip everyone with that clear decision matrix. We'll start at the very beginning, the fundamental mechanical differences in kids' bones.
Well, what's fascinating is that pediatric bone is not just a small version of adult bone. It has unique biomechanical properties.
And that dictates how it breaks.
Precisely. The most critical factor is the periosteum, that thick, fibrous sheath around the bone. In children, it's significantly stronger, much more robust than in adults.
And on an X-ray, what does that strength practically mean for us?
It means you get limited displacement. That thick sleeve often acts as a sort of hinge, preventing the bone ends from completely separating.
And that's where we get those classic pediatric fracture patterns from.
That's it. You get the greenstick fracture, where one side of the cortex breaks but the other just bends. And you get plastic deformation, or bowing, where the bone absorbs the energy just by bending, without a clear fracture line.
So if the periosteum is this limiting factor, the weak link has to be the physis, the growth plate.
Exactly right. Mechanically speaking, a child's ligaments are often stronger than the physis itself. So a force that might cause a sprain in an adult.
In a child, it just shears right through the growth plate.
It shears right through the weakest part, which is that growth plate. Specifically, it's a layer called the hypertrophic zone.
The hypertrophic zone, why there?
It's where the cells are rapidly expanding,
Yeah.
and it's the least mineralized part of the structure, so it's the least stable. Understanding that the fracture almost always goes through that zone is key.
Which brings us to the classification system we all have to be fluent in. Salter-Harris.
Yes, this is your shorthand with the orthopedic team. The mnemonic we all use is SALTER.
Right, so S is for straight across, type I.
Straight across the physis. The epiphysis separates cleanly. And these are the tricky ones because they can be so subtle on an X-ray.
Let's just pause on that for a second. The type I is the one that can trip people up because the X-ray often looks completely normal.
Exactly. A Salter-Harris type I is often occult on those first films. So if you've got a child with focal tenderness right over the growth plate, you have to treat it as a type I fracture clinically.
Regardless of what the film says.
Regardless, you splint it, manage the pain, and you explain to the parents that the diagnosis will likely be confirmed on follow-up films in a week or so when you see new bone forming.
That's such a high-yield clinical pearl. Okay, back to the mnemonic.
So next is A for above the growth plate. Type 2. This is the most common type. The fracture runs through the physis and then exits up into the metaphysis.
And these usually do well with a closed reduction.
They do, because that periosteal hinge is often still intact. Then we have L for lower or below, which is type 3. This one goes through the physis and then down into the epiphysis.
And crucially, it crosses the joint surface.
It crosses the joint surface, and the moment that happens, the stakes go way up.
Which leads us to T's for to or through.
Type 4. This one is really unstable because it crosses all three layers: epiphysis, physis, and metaphysis. And finally, the rare one, ER for erasure or crush.
Type V, a compression injury.
A compression injury that crushes the physis. It has the worst prognosis, often leading to growth arrest. So as a rule, the risk of problems increases as you go from type I to type V.
Okay, that's the technical context. But before we get to reduction, we have to talk about the non-negotiable red flags for non-accidental trauma.
Yes. This has to be at the front of your mind in every assessment, especially with a non-ambulatory child. The patterns that should make you stop and immediately involve the child protection team are things like metaphyseal corner fractures.
Sometimes called bucket handle fracture.
Exactly. If you see those, or long bone fractures in a child who isn't walking yet, or multiple fractures in different stages of healing, the red lights should be flashing.
It's not just the x-ray, is it? It's the whole story.
It's the whole story. An implausible mechanism of injury, or conflicting stories from caregivers, all of that elevates your suspicion immediately. Our first duty is to the child's safety.
Absolutely. Okay, let's pivot now to the acute decision-making. We've got a displaced fracture. It looks accidental. A complete, a greenstick, a Salter's first or two. This is where those age-based thresholds are our guide.
This is the matrix. This is where we use our knowledge of pediatric remodeling. And ED doctors with the right training should be doing these reductions. But you have to know these acceptance criteria by heart.
So let's start with the youngest, the 0 to 5-year-olds. The remodeling capacity is huge.
It is extraordinary. For these little kids, you can potentially accept residual angulation of up to 35 degrees.
35 degrees, that feels... Well, it feels massive compared to the standards for an adult with a collis fracture.
It's a complete paradigm shift. We're not aiming for anatomic perfection on an X-ray. We're aiming for function, which relies on growth. You have to trust that the distal radius physis, which provides 75% of the arm's growth, will literally straighten that bone out over the next few years.
Okay, so up to 35 degrees angulation. What about displacement?
Tilt can be up to 15 degrees, and even 100% displacement of bony width is potentially acceptable as long as the length is okay and the fragments are touching.
Right. Now what happens when we move up to the next age group?
For the 5 to 12-year-olds, that remodeling capacity starts to diminish, so our tolerance drops. Angulation is now limited to about 20 degrees.
Still quite a bit.
Still a lot, yes. Tilt stays around 15 degrees and displacement should be tighter, maybe 50 to 100% contact.
And then for the older kids, over 12.
Over 12, the physes are starting to close, so the rules tighten almost to adult standards. We're aiming for angulation of maybe 15 to 20 degrees max, tilt under 10 degrees, and displacement less than 50%.
So you're functionally treating them almost like an adult.
Almost. And if the physis has closed, you are treating an adult fracture, and the acceptable angulation shrinks right down. The clock has run out on growth.
That matrix is so important. Now for the hard stops, the absolute contraindications. When do we just call for an urgent referral?
First and foremost, any open fracture. That needs a formal washout in theater.
No question.
Second, those unstable Salter-Harris types we mentioned, types 3, 4, or V, because they cross the joint surface or have a high risk of growth arrest, they need specialist management.
We're not touching intra-articular fractures in the ED.
Correct. And finally, any forearm fracture that's complicated by a joint dislocation, think of a Galeazzi fracture dislocation, a radial shaft fracture with a DRUJ dislocation. That needs an orthopod.
Okay, so let's say we have an 8-year-old with a straightforward displaced Salter-Harris type 2. It meets our criteria, we're going to manage it. Talk me through the procedural mastery. What happens before we even touch the patient?
Preparation is everything. Step 1, a careful, documented neurovascular exam before you do anything.
Before. Always.
Always. Step 2, informed consent, including the risk that the reduction might not hold. And third, procedural sedation. That requires a dedicated person monitoring the patient who is not involved in the reduction itself.
Right. Patient safe and sedated. Now the mechanics.
First, you have to overcome the muscle spasm, so longitudinal traction. You can have an assistant provide counter traction, but ideally you use finger traps.
Suspended with a bit of weight.
A bit of weight, 5 to 10 pounds. And here's the crucial part. You have to leave it for at least 5 minutes.
5 minutes. You can't rush that part.
You cannot. Rushing means you're fighting the muscle and you'll fail. Once you have that relaxation, if the fragments are overlapped, you might need to actually increase the deformity first.
Bend it more to unhook the end.
Exactly. You unhook the ends, and then while maintaining traction, you use your thumbs to push the distal fragment back into place and straighten the arm.
So now we've got length, but maybe there's still some residual angulation. What's the maneuver there?
Now it's about molding. You keep gentle fraction on, but you're primarily using pressure. For an apex volar deformity, you slightly pronate and press on the apex. For the more common apex dorsal deformity, you slightly supinate and press dorsally.
You're using that pressure to neutralize the muscle forces while the cast is setting.
Precisely.
Okay, let's talk about the cast. Long arm versus short arm for these distal fractures. What's the thinking?
The evidence actually leans toward a short arm cast for most true distal fractures, unless the child is very young and non-compliant. A short arm cast is usually enough to control rotation and hold the alignment.
And what's the most critical technical step while you're actually applying that cast to make sure you don't lose the reduction?
This is the high-yield nugget, three-point molding. If you skip this, your reduction will fail. You have to maintain the forces you use to reduce the fracture as the cast hardens.
So 1 point of pressure over the apex of the fracture.
And 2 counterpressures, proximal and distal on the other side. You're basically locking it in place.
I remember reading about the shape of the cast too, and it shouldn't be round.
No, absolutely not. A round cast has no mechanical strength against angulation. You want to mold it so it's wider in the AP diameter than the lateral. We aim for a lateral to AP ratio of about 0.7. That oval shape gives your 3-point mold real mechanical advantage.
That's a detail that really makes a difference. Okay, let's finish with vigilance. Post-reduction checks, discharge advice, the acute safety measures.
The biggest acute worry is compartment syndrome. If it was a bad fracture with a lot of displacement, you have to assume there will be significant swelling. In those cases, the cast must be longitudinally split.
And not just on one side.
On both sides, bivalved, all the way down through all the layers. Then you wrap it with a loose elastic bandage. If in doubt, split it.
What's the immediate post-cast check we're looking for that signals trouble?
You do your full neurovascular assessment again, good perfusion, of course. But critically, you check for pain on passive extension of the fingers and thumb.
That's the one.
That's the one. Excruciating pain on passive stretch is a massive red flag for compartment syndrome. That is a surgical emergency.
So once we're happy the limb is safe, what are the crystal clear instructions for caregivers on when to come back?
They need to know the tight cast symptoms. Severe pain that isn't helped by pain relief and elevation, not being able to move the fingers, cold or blue fingers, or any new numbness or tingling. They come back immediately for any of that.
And finally, the orthopedic handover timelines.
If you've put on a definitive cast, they need ortho follow-up within 1 week for a check x-ray. But if you've only put on a temporary splint because of swelling, they need to be seen much sooner to get their definitive cast.
How soon?
Within 2 to 5 days. Any longer, and you risk losing that careful reduction you just achieved.
Here's where it gets really interesting. Because our job isn't just managing these obvious fractures. It's also about not missing the subtle, high morbidity injuries that can look like a simple sprain.
Yes. You have to keep a high index of suspicion, especially with wrist pain in adolescence. You have to rule out a scaphoid fracture.
It's one we all worry about missing because of a vascular necrosis.
Absolutely. You must check for snuff box tenderness. If it's tender clinically but the x-ray is normal, you can't just send them home. You have to immobilize them in a thumb spica and arrange for repeat imaging.
And what about the other side of the wrist? The ulnar side?
You need to think about TFCC tears, the triangular fibrocartilage complex. That presents as ulnar-sided pain. You look for tenderness just distal to the ulnar styloid or pain with specific maneuvers. These need a proper referral, often for an MRI. You can't just label it a wrist sprain.
So what does this all mean? It means those decisions you make about accepting, say, 15 degrees of angulation in an 8-year-old, they rely entirely on your ability to predict their remaining growth potential.
Exactly. And you have to remember the sheer power of that potential. The distal radius physis contributes 75% of the radial longitudinal growth. So think about it. How does that knowledge change your threshold for accepting that 15 degrees of angulation in a 6-year-old versus the exact same fracture in a 14-year-old whose growth plates are starting to close? That calculation, that's our ultimate responsibility in the ED.